Good Tuesday afternoon. I'm Dr. Martha Buchanan, Senior Director and Public Health Officer here at the Knox County Health Department. Our moment of gratitude today is dedicated to Dr. Keith Gray, Chief Medical Officer at the University of Tennessee Medical Center, who will be joining us today to speak about how COVID-19 is affecting our regional hospital systems, and I will turn it over to him in just a few minutes. But first, I want to spend some time talking about some changes that are being implemented in public health across the state and here in Knox County. We spoke last week about our plans to review our contact tracing strategy and identify ways we can best prioritize this process. There are several reasons for this: increasing case volume, laboratory processing lag times, and continuing challenges with the statewide laboratory reporting system. Because of these factors, the Tennessee Department of Health has implemented the CDC recommendations for prioritizing case investigations and monitoring. Accordingly, we will align with these recommendations here in Knox County, and we will be implementing the following after consultation with our epidemiology team. Case investigations will be prioritized for COVID-19 cases reported to us within 6 days of their test date, except for cases 18 years and old or younger, and 60 years old and older. We will continue to investigate all of the cases in the latter two categories in an effort to reach the two priority populations. CDC recommends, those at high risk for poor outcomes and those who are at highest risk for being in a congregate setting, such as a school or long-term care facility. We will also prioritize our contact tracing efforts to reach these same groups. This change is an effort to gather the most essential information quickly and keep the most vulnerable populations protected. This is a necessary step to strategically allocate our resources at this stage in the pandemic, and is being done in many areas across the state. Contact tracing is a highly effective tool, but it does have its limitations, especially in a pandemic. As we've stated previously, conducting contact tracing during widespread community transmission, like we have right now, is not as effective as it is earlier in the pandemic and is when we are managing a traditional outbreak. Moving forward, to best serve the public, we must facilitate our response in a way that will have the most impact on our community. This is especially true as we consider the resources needed for vaccine distribution, which is right around the corner. What this means to folks in the community is that not all new cases will get a call from public health. So we recommend that all positive patients immediately isolate upon learning of their positive test result and notify their close contacts of the need to quarantine. As we have said before, do not wait to receive a call from public health to start taking action. Additionally, anyone who gets tested for COVID-19, regardless of symptoms or reason for testing, should isolate until the results come back. We're also calling on our local medical providers who are offering COVID-19 testing to provide their patients with isolation and quarantine guidance so their patients can start following these immediately, much like they do every day for other illnesses. We've created a section on our website that includes not only the isolation and quarantine guidance, but also a quarantine and isolation calculator from the state that folks can use to determine the appropriate timeline for isolation and quarantine. That website can be found at covid.knoxcountytn.gov/prevention-and-support. Because of these changes, this also means that we will no longer be providing proof of quarantine or return to work letters for everyone. Employers should visit the webpage I just referenced and share the isolation and quarantine guidelines with their organizations. It's incredibly important that individuals take personal responsibility. Employers utilize their standard infection control procedures to implement proper safety precautions based on the guidance we have on our website, much like they do for every day for other illnesses. Individuals identified as a confirmed case or a close contact should refrain from reporting to work, or church, or school, or Bible club, whatever, wherever you want to, wherever you go, until their isolation and quarantine period is over. That reduces the risk for all the people in those situations. Finally, I want to offer a comment on the timing of these changes. The local situation is the worst we have seen, and the entire system is fundamentally overwhelmed. Cases are increasing at a rapid rate, hospitalizations are incredibly high, and most tragically, the past couple of weeks have been the deadliest in our community regarding COVID-19. Given the current circumstances, we must be strategic in how we prioritize our portion of the response to have the most impact we can possibly have. It would be irresponsible of us not to address the difficulties head on. Throughout this pandemic, we have been forthright with the challenges we are facing. From the lab processing delays to challenges with the lab reporting system, to additional challenges with the growing case volume that we're trying to manage. Additionally, we have stated very directly that with community-wide spread, contact tracing fundamentally becomes less effective. We don't want this announcement today to be perceived as rolling back our response, because that couldn't be further from the truth. We are not giving up. We are still in this fight, and we are not going anywhere. However, we are at a critical turning point. We are making the changes we need to make to have the most impact in this battle. And now I implore you, all the members of our community, to please do your part to help shift this trajectory. You know what to do. We've told you 1,000 times. So please do your part to keep your community healthy. Take a step back and think about how your actions impact the rest of our community, and do not give up. And now I'll turn it to the local situation. We have 450 new confirmed cases since yesterday's report. That is a record for a new daily increase, giving us 21,178 confirmed cases of COVID in Knox County since March. Additionally, we have 1,236 probable cases. 19,274 of our cases are considered inactive, giving us 2,946 active cases. Due to a system coding issue, we are experiencing data lags in updating the number of inactive cases. We expect this issue to be resolved in the coming days. 634 individuals have been hospitalized at some point in their illness. 142 Knox County residents are currently hospitalized. And sadly, we have 5 additional deaths to report, raising our total to 194. And now I'll turn it over to Dr. Gray.
Thank you, Martha, and thanks for the opportunity to be here to represent the health systems. And again, it's always my pleasure to be a part of what the Knox County Health Department is doing and continue our collaboration in helping keeping the community safe. I want to start with some overall numbers, which Martha just alluded to. We are in a predicament that we haven't been in before during this pandemic. We've seen a significant increase in the number of new COVID cases in Knox and surrounding counties, really since October 1, but a precipitous increase since November 1st. In Knox County, in November alone, of those 21,000 cases that Martha just mentioned, we had almost 6,000 cases just in the month of November. And we're on a even increasing trend for the month of December. Looking at Tennessee Hospital Association data, which is Knox and surrounding 10 counties, we've had over 14,000 cases in November. And again, we're on pace to break that record for December. The doubling of the test positivity rate has occurred since July, and nearly 50% increase in the test positivity rate since our last spike in September. We expect to see daily new cases to continue to increase secondary to the Thanksgiving holiday, which we're starting to see the impact of that this week, and the rest of the holiday season, which will extend through early January. As you know, hospitalizations follow new cases, and we're breaking new hospitalization records really on a routine basis. Yesterday, we had a new record with over 500 hospitalizations in our region, and another 77 of those patients with suspected COVID. We had a 10% increase in hospitalizations just over the weekend, And those hospitalizations, again, are expected to lag behind and climb through the new year, possibly into February. 22% of those hospitalized patients are in the ICU, with 53% of those in the ICU being ventilated. The demographics of these patients that are being impacted during this current spike over the last 2 months include those that are over 50 years old. That's where we've seen the most significant increase in the number of new cases and hospitalizations. The majority of those in the hospital that are in our acute care beds and also in our critical care beds are age 60 plus. I was not able to be with you last week, but as you know, on December the 2nd, last Wednesday, the Knox County Health Department indicated that our capacity benchmark went to red for the regional hospitals for the first time in the history of the pandemic. What that indicates is that the resources of the hospitals are being challenged, and I would say stressed, by our current inpatient volumes. While reaching the red benchmark is serious, first and foremost, we want to remind you that all of the hospital systems remain open, and we believe that it is safe to visit the hospitals should anyone need medical care. Again, Covenant Health, East Tennessee Children's Hospital, Tennova Healthcare, and the University of Tennessee Medical Center continue to work collaboratively to keep our facilities open and to make them safe for our patients, our visitors, and our team members. We are continuing to segregate COVID patients from our non-COVID populations. We are continuing to limit visitation as we have in the past. We are continuing to wear masks as team members and require masks of our patients and visitors. And we believe that our testing capabilities and our PPE supplies remain adequate. Also, our health systems are continuing to work together to care for all patients in need, not just our COVID patients. If an individual or loved one needs medical care for situations such as heart disease, surgery, trauma, injuries, or other major illnesses, we stress for you not to delay seeking medical attention. Again, our hospitals are safe and they are open, and we welcome those without COVID to our facilities. As the number of COVID-19 cases continue to increase in our regions, we are pleading with everyone to do his or her part, as Martha has already emphasized today. While we are continuing to create surge space to meet the needs of our community, the health systems all are considering deferring non-essential procedures, just like you've seen at Ballot Health, and also as you've seen from the Vanderbilt announcement last week, deferring those procedures that require an overnight stay in order to create staff and capacity within our hospital systems to take care of all the community needs. Further deference of non-essential procedures may be needed in the future to create additional capacity and also to create staff. The community spread of COVID has had a significant impact on our staff, like it has many other essential community workers, with increasing numbers of our healthcare workers isolated or quarantined each day. We understand that many of you are experiencing COVID-19 messaging fatigue, but now more than ever, it is imperative for us to consider how our actions affect others. Keeping up with COVID-19 preventative behaviors will be beneficial not only to your health, but to the health of your neighbors. Therefore, again, as Martha has already emphasized, and as she has been emphasizing for the last 9 months, we are asking you to be in compliance with the 5 core measures: physical distancing, at least 6 feet, and not gathering in large social gatherings, wearing a mask or cloth face covering, practicing proper hand washing, cleaning and sanitizing high-touch surfaces, and staying at home when you are sick. And the last thing I just want to offer, really the same sentiment and word of encouragement that Martha offered. We have an opportunity to be victorious if we just would not allow ourselves to grow weary or become discouraged in doing what we know is right and what we know is good. We will emerge victorious if we do not give in. As Martha also mentioned, help is on the way. We are expecting our first doses of the vaccine to arrive on or shortly after December 18th, which will give us an opportunity to vaccinate our frontline workers, our healthcare providers. And shortly thereafter, we hope that a phased vaccine distribution and administration plan will be available for our community members in early 2021. I'll stop there and allow opportunities for questions.
All right, thank you, Dr. Gray. We'll bring Dr. Buchanan back up. For those reporters in the Zoom meeting right now, please go ahead and submit your questions into that chat feature for either Dr. Gray or for Dr. Buchanan. First question we have is from Megan with WVLT. Have any hospitals needed to divert patients? If so, when and for how long?
So again, I just make sure my mic is still on. We've all talked and had discussions about deferring non-essential procedures. How that looks in each individual health system and at each individual hospital will be different. As you know, Tenova and Covenant Health have a multi-site system. The University of Tennessee Medical Center has one major hospital. I'll speak for our campus. We have, as of Monday, as of yesterday, begun deferring non-essential inpatient procedures. And again, those are non-essential people that the clinicians have deemed have illnesses or required surgery that can be deferred to a later date, not indefinitely. We are specifically targeting those patients that require an inpatient bed in order to create capacity for the other needs of our community. And also, we know that when we create that capacity, it also creates staff that can be used in a flexible way. And again, other health systems are making the same considerations.
The next question we have is from Megan with WVLT. She asks, are any National Guardsmen being called into hospitals or other facilities in our area?
We know that resource has been made available by our state leaders, but as of yet, we have not utilized the help of the National Guard to help us with hospital operations.
All right, the next question also from Megan with WVLT. Have any hospitals needed to utilize surge ICU beds?
Well, and again, we'll use surge in quotes. Have we had to create new beds that aren't part of our traditional licensed bed number? The answer is yes. We're being creative in creating space within our hospital to accommodate our needs, whether they be critical care needs or acute care bed needs. And again, the fact that we're considering deferring non-essential procedures means that we're in a surge state at this point.
Next question we have is from Annie with WBIR. Are these case increases the post-Thanksgiving surge? When did we start seeing those?
Sorry, I was having to think and do a little math in my head. So yeah, this week is when we would anticipate seeing the post-Thanksgiving surges or increase in cases because we're far enough out from Thanksgiving for that.
The next question we have is from Jeff with WATE for Dr. Buchanan. Can you clarify the process for self-notifying potential close contacts? If a person tests positive and they're not part of the contact tracing groups, who all should they call? Coworkers, restaurants where they might have eaten?
So if you look at the close contact definition, it's somebody that you spent 15 minutes or more with, either all at once or cumulatively over a 24-hour period, whether you're wearing a mask or not, and within less than 6 feet of that person. So those are the people. So, somebody maybe you had lunch with, obviously your household contacts, if depending on what your work situation is, if your work doesn't allow for 6 feet of physical distancing, you might have to notify some of those folks. Things that people might not think about, like a meeting that you had at work where you're all around a conference table, and everybody was with less than 6 feet of each other, then those folks all need to be notified. If you went out to lunch with your work buddies or your whoever buddies, and you were within less than 6 feet of those folks for more than 15 minutes, you need to notify those people that you're a case. And they need to quarantine, which means they need to stay home and not go to work and not go out for 14 days. Quarantine guidelines have changed, but 14 days is the maximum and ideal, or 10 days if they don't have symptoms, and 7 days if they don't have symptoms and they have a negative test. So that's why the calculator is really useful for you to be able to figure that out and for them to be able to figure that out as well. And I think one thing to keep in mind is that COVID-19 is a social virus. So that's how you're going to pass it to other people. It's really social interactions, social gatherings where people are getting close together and staying there for a while. And then of course in your household, I mean, you're gonna be within 6 feet for more than 15 minutes usually with people in your household.
The next question we have is from Annie with WBIR. The numbers today look very bad. Do you expect them to get worse or better over the next week?
Well, if I were in predicting, I would say they're going to get worse. We expect them to get worse and then probably continue kind of in this upward trend through the holiday season and probably through the first of the year, unfortunately. So that's why it's so important that each of us does our part all the time to reduce that trend. Go ahead and prove me wrong.
From Scott with Compass, with the change in contact tracing, will you begin releasing cluster information?
No, that won't change.
From Jordan with WTBC, Hamilton County's health department recently stopped posting hospital capacity numbers, saying they could be misleading. We'd like to know why Knox County makes that data available to the public.
That was a decision we made in concert with our hospital partners. It's taken out of this reporting system that's used across the state and actually across the country, hospital resource tracking system. Each hospital puts their information in there. It is dependent on the hospital's reporting, and we've been very transparent. There are times when things happen and the hospital report doesn't get in there for various reasons. We work with them to correct that problem. And it's just a snapshot in time. It really is just telling you the situation at the time we pull the data out of that system.
The next question we have is from Annie with WBIR for Dr. Gray. Have any hospitals already pulled back on normal operations like elective surgeries because of the surge? Please answer yes or no.
Yes, as I mentioned before, I speak personally for the University of Tennessee Medical Center. We have begun deferring non-essential cases that require an inpatient stay, whether that's one night or an anticipated 5 nights. We have deferred some of those procedures already.
The next question we have is from Vincent with the Sentinel. What is the Knoxville Hospital District occupancy rate? How many hospital beds, ICU beds remain open?
And as Martha mentioned before, that number is really dynamic. And so even if I were to say a specific number right now, that number would likely be different by the time this conversation were over. Right now, we do have capacity in acute care beds, and we do have some capacity in our ICU. That fluctuates on an hourly basis, on a day-to-day basis, and it also fluctuates dependent upon the number of new cases. Because when we see a spike in new cases, like we have today, we can expect that there are going to be a predictable number of hospitalizations associated with that in the coming weeks. And so again, I push back and say we're continuing to partner with the community to do the right things to slow the spread of the disease so that we can continue to have capacity.
And our benchmarks will be, as you know, updated tomorrow.
The next question we have is from Annie with WBIR, also for Dr. Gray. Can you give a concrete example for what you mean when you say creating surge space? What does that look like? Beds in hallways, non-ICU beds turned into ICU beds?
So there are levels of surge, and I would say we are in the earliest phase of surge. We're utilizing beds for routine patient care that may, for example, used to be recovery room beds. And this is just for an example, and it may not apply to all hospitals in the same way. So if those beds used to recover post-surgical patients, they may become acute care beds or they may become ICU beds, depending upon what the need is. There's certain facilities requirements for each bed to determine what that bed can become in the future. But we are now creating new spaces in our facilities to accommodate the surge in hospitalizations that we've seen over the last several weeks.
And just to provide just a time check for everybody, we've about 6 minutes left. There's quite a few questions still in the chat feature. So we'll go through the questions that are currently in the chat feature with the last one from Annie with WBIR, just because that will likely take us right up to 1 o'clock. So the next question we have that's been submitted is from Annie with WBIR. To clarify the contact tracing changes, am I correct in understanding everyone over 65 and under 18 will still be contact traced along with everyone who public health is notified within 6 days of the test?
It's correct with one exception. It's everybody 60 and older will be contact traced, not 65.
And also from Annie with WBIR, this one's for Dr. Gray. On a scale of 1 to 10, how bad is this right now? Please use a number.
Well, it's impossible to use a number because if you had asked the same question back in July, we would have all chosen a number that was likely greater than 5, and it would not have allowed us room to accommodate what we're accommodating now. And if I say 10, then that means we can't do any more than we're doing right now. So I don't know the answer to that. It's the worst that we've seen during the pandemic. And I agree with Martha that I think it will become worse before it gets better, regardless of what we do. But in order to not make that impact protracted through the beginning of 2021 and into February, it's incumbent upon our community to adopt and adhere to the 5 core measures.
Next question we have is from Jeff with WATE for Dr. Buchanan. We've heard KCHD mention 5 core actions consistently, yet cases continue to rise. Is that evidence of people not following the guidelines, or is there a limit to how well the 5 core actions can work?
Well, the 5 core actions are not perfect. They slow transmission and reduce risk for passing COVID-19 to others. But I would say it's evidence that people are not consistently following the 5 core actions. The challenge with this is that COVID-19 doesn't take some time off when you're just having dinner with your family or your friends, or when you're at a meeting with your coworkers, or you're at that celebration for Christmas or Thanksgiving or whatever. It doesn't take time off. It's still there. It's still being passed. It's still being shared, just like your socialization. So that's the problem. COVID-19 requires us to rethink how we socialize and rethink how we do that and take steps to protect ourselves and the people that we socialize with. And I'm assuming you care about the people you socialize with. So take a step back and rethink how you socialize. How can you do that in a mask or maintaining 6 feet of social distancing? Those things are imperative to reduce the spread of this disease.
Next question we have is from Vincent with the Sentinel for Dr. Gray. Can you please confirm whether UT Medical Center has begun deferring procedures or whether it is still considering doing so?
Yeah, again, I think we've answered that question several times, that we have begun deferring non-essential procedures that require an inpatient stay. However, we are leaving that decision-making as to what defines a non-essential and essential procedure up to the clinician. Each clinician has a unique relationship with their patient, and it is not up to the hospital to decide what is essential and what is not essential. What may be considered non-essential in one patient could be essential in another, depending upon that patient's particular case and their relationship with their physician. So we have begun that this week. We're in the early phases of that, but we're leaving that decision making up to the patient and his or her relationship with the clinician.
I see a question here from Jeff with WATE that looks to be along the same lines of that question. So I don't know if Dr. Gray, there's something else you want to add. Jeff asks, you mentioned deferring non-essential procedures. What specific metric or metrics will you use to make that decision, and what portion or how many roughly procedures are non-essential?
Well, we don't, again, that's all relative. It depends on the number of beds we need. Again, our purpose in doing that is our need to create capacity and also to create staff. We had different constraints in the spring. Our constraints in the spring were capacity. It was PPE and it was testing. We do not have constraints related to PPE or testing, but we do have constraints related to capacity just based on the sheer volume of the number of new cases. And we have constraints related to staff because not only are we seeing an increase in the requirement of our staff, but we're seeing staff increasingly impacted by COVID in the community that decreases the number of staff available to carry out our operations. And so our goal in deferring some of those non-essentials is to create capacity and staff. And this is not unlike what is happening around the country and also in our own state, specifically with Ballot Health and also with Vanderbilt.
Another question from Annie with WBIR for Dr. Gray. Given sick and quarantined staff, what is your current staffing level compared to normal? And she's asking you to estimate with a number.
I don't have a number. I will say that we have great leadership at the nurse level, at all levels of our team members, and we have staffing models that we've created and that we had an opportunity to create during the last shutdown of our systems in March and April. And so we're using those creative staffing models to take excellent care of our patients. Remember, our top priority is team member safety and patient safety. And there's no creating staffing model that we will create that will compromise either one of those.
All right, we have time for just the 2 more questions. They're both for Dr. Gray, both from WBIR. The first one is, are you looking at alternate care sites? If so, please elaborate on where.
Currently, we are not looking at the alternate care site model. We believe that we have the capacity to meet the healthcare needs of our COVID and non-COVID patients here in our community. Again, it may require change in operations. It may require creative staffing models, but we do believe that we have to surge capacity within our healthcare systems to take care of the needs of our community.
And the last question, are any hospitals in Knox County using mobile morgues? And how soon do you expect to require additional morgue capacity in your hospital?
I am not aware that any hospital in our region is using the mobile morgue model. And I am not sure when that need will present itself or if it will present itself. But again, we can mitigate that by partnering with the community to carry out the 5 core actions.
All right, that is it for today. So thank you all for your time, especially Dr. Gray for joining us again. We hope you have a safe rest of your day, and we will see you all again on Thursday at 12:30. Have a good rest of your day.